Moving on to the upper limb, things can get a little tricky, and yet again our two variations of the dermatome maps present significant differences. The Keegan and Garrett map presents the C5 to T1 dermatomes as running continuous from the spinal cord, along the length of the upper limb, whereas the Forster maps showed 5 to T1 dermatomes as being discontinuous in appearance. But how could that be? Well, in order to understand the organisation of the dermatomes of the upper limb, we have to go back, way back, to embryonic development. In the early stages of fetal development, we see segmentation, with each segment representing a different spinal level and therefore a different dermatome. From here on, the limb buds start developing laterally and forward, away from the body. So far so good, because the dermatomes are still just in sequence with the trunk. The upper bud is innervated by spinal nerve C5 to T2. As it grows and elongates, it pulls the anterior parts of the C6 to C8 dermatomes into the limb. So on the anterior aspect of the body, C6 mainly innervates the area over the thumb, C7 the middle finger, and C8 the little finger. The index and ring fingers are too variable to ascribe to any one dermatome. You'll see the same arrangement on our dermatome map. From an anterior perspective, the C6 to C8 spinal nerves provide cutaneous innervation for the hand. As a result, in the pectoral region, the C5 dermatome lies immediately adjacent to T1. This is the only area of the body where there's no overlap of dermatomes, and therefore the bands are very clearly defined. However, the dermatomes are continuous on the back. Right, so let's move on to the lower limbs, where unfortunately the disagreement continues in our two primary dermatome maps. Similar to the upper limb, the Keegan and Garrett map presents swirling unbroken dermatomes which extend from the midline until their termination in the lower limb. The Forster map, on the other hand, presents more segmented dermatomes. The L2 and L3 dermatomes appear reasonably similar in both maps as they are mostly contained to the area above the knee. The differences become especially apparent in the L4, L5 and first sacral dermatomes, which extend from the lower trunk all the way down to the leg and foot in the Keegan and Garrett map, but are discontinuous and mostly distal to the knee in the Forster map. This obviously can create a lot of confusion. For instance, if you had a patient who presented with altered sensation on the anterolateral thigh, it's possible to localize the injury to the L2, L3, L4, or even L5, depending on the map you use. Well, in order to understand the organisation of the dermatomes of the lower limb, let's look again to some embryonic development. In the early stages of fetal development, we see segmentation, with each segment representing a different spinal level and therefore a different dermatome. From here on, the limb buds start developing laterally and forward, away from the body. So far so good, because the dermatomes are still just in sequence with the trunk. The lower limb is innervated by spinal nerves L2 to S3. As it grows and elongates, it pulls the anterior parts of the L3 to S2 dermatomes into the limb, creating discontinuous dermatomes. This explains why L2 and S3 are bordering each other in the inguinal region.
If you found this quick anatomy or physiology video helpful, you'll enjoy our video tutorials even more. Click on the button and you'll see what I mean. We have hundreds of videos available to our premium members, not to mention all the fun quizzes, complete articles, and atlas sections to solidify your knowledge. Click on the button in the middle to watch the full-length video and master anatomy and physiology.